You're listening to The Q Switch with your host, Spence.
Welcome one and all to the Q Switch Conversations podcast. I'm your host, Spence. The mission of this show is to tackle subjects currently impacting ophthalmology and pull in leading eye care professionals and industry players to discuss their unique perspectives. So let's jump right on in. We've got a big fish for you on this episode of the Q Switch. Let me just say, if you are in any way associated with Retina or Ocular Oncology and you don't know the name Tim Murray, then you're probably doing something wrong. Dr. Murray is founder and CEO of Murray Ocular Oncology and Retina right here in Miami, Florida. He has a storied career and is recognized globally as a thought leader in the field. Get this, he's published over 250 peer-reviewed articles and chapters in the field of vitreoretinal surgery and ocular oncology. Dr. Murray has been recognized with honor and senior honor awards by the American Academy of Ophthalmology, the Association of Research in Vision and Ophthalmology, ARVO, the Retina Society, the American Society of Retina Specialists, and the International Society of Ocular Oncologists. Dr. Murray, it is a pleasure to have you join the show. Where are you calling from today?
Spence, welcome. I'm in my office in Coral Gables, Florida, about 30 minutes from Bascom Palmer.
Very well. Having lived here myself, I know exactly where you're at. In fact, we've actually spent some time together at your office. So in this episode, Dr. Murray will give his take on scaling ophthalmic practice and share the common struggles and solutions that come with taking on such an endeavor. Dr. Murray, again, glad to have you on the show. So let's pop the top off on this thing and have you share the origin story of how you decided to hang your own shingle. And by that I mean, what motivated you to open and scale your own retina and ocular oncology practice, and how did you envision it being different from a traditional academic or hospital-based setting with which you had spent the majority of your career up to that point?
Right. So I came out of fellowship and went to Bascom Palmer to direct the ocular oncology service and the imaging service in 1991. And Spence, I was there for 20 years. It is an incredible institution, but things were changing at the academic center level, both at the University of Miami for Bascom Palmer and at other institutions. And I had a unique opportunity to take a very well-established practice and move it outside of the academic center. And I was interested in doing that for a number of reasons, but it was the first time I really felt like I had control of my practice and the environment that I saw my patients in. So I did that in 2012. So I've been here at Miami Ocular Oncology right now for 13 years. So 20 plus years at Bascom Palmer, 13 years here. I feel like I've had two different careers, one in academic ophthalmology and one in private practice. And it does give you such a unique insight. Now you realize the field has changed even again, because when I started, it was academic ophthalmology or private practice or the VA. And now we know a major player in our field is private equity, and equity has really expanded its reach in ophthalmology and in retina. So when we look at what the younger people are coming out to, it's very different than it was when I started in my academic practice, and it's also very different than when I started in my private practice. So it's really been interesting because so much has changed. I teach residents and fellows. I'm always about what you need to learn to do is to learn continuously, because what you're going to do now and the equipment you're doing this with may be totally different in 10 or 20 or 30 years. And that's been the crux of my entire career, is to see these fluxes in technology and fluxes in approach, both medically and surgically. Kind of exciting.
Well, launching is one thing, but scaling brings a whole new set of challenges. What were some of the biggest financial or operational challenges you faced in the early stages of scaling, and were there any surprises that forced you to rethink your strategy?
Yeah. So most people, and you're absolutely correct, most people when they go into particularly a private practice, they'll typically start small and they'll scale up. Okay, because it's very unusual to have an established practice when you start. When you start with an established practice, you've usually joined a group, they have you in a new location and you're there. But for me, the things that were key was And I was lucky. I'd got my MBA in 2016, so I had an MBA with me. In 2006, I had an MBA with me. And so I was able to I met with a local boutique bank, for example, that specialized in medical infrastructure, because I did two things. I bought my office as opposed to lease, which most people don't have that option. But if you can, boy, in the Miami market, I'm a good doctor and a good surgeon and a good specialist. Realty kills everything. So my office has appreciated more than any other part of this. So that was a blessing, and I was lucky enough to be able to do that with a group of bankers. What was hard with the bankers was that coming from an academic practice, they want your financials, and you really don't have financials in the way that a bank wants them from academics. I was lucky I could restructure some of my information for the bank to give them a better idea. So I think they still took a risk in me because I was a non-traditional, person to loan to in this environment. So bought my practice, and when I bought it is two practices joined together. It was owned by a plastic surgical group. It has two operating rooms incorporated into the practice and two procedure rooms. And I bought it thinking I had about 30% more space than I needed. And the idea was I would start, and then if I needed that, I'd grow into the space. Spence, literally within 3 months, we were using every fraction of this office space. And so the other thing is I bought units that were multifunctional. When I went into the imaging space, I was a big person that believed in Heidelberg for the quality of imaging in the macula. So we went with multifunction Heidelberg units. When Optos became available with an integrated wide field OCT, I bought that because so much of my patients have pathology in the periphery. And it was important because I had space for each of these sets of equipment to allow my imaging staff to float. The blessing that I've had in starting and maintaining the practice is who you bring into your practice, who your support team is, your front desk, your financial, your back office, your tech, your imager, your ultrasonographer. They make or break you. And so I was able to move from Bascom Palmer and take some of those key people with me. And I feel like that gave me a jump start. And then I came in, Bascom Palmer at the time didn't have an electronic medical record, but it was obvious that was going to be a necessity moving forward in the future. So I established an electronic medical record from the beginning, and the decisions about site-based or web-based structure and integrating a front-end office manager with your back-end informatics. There's a lot to it. So the take-home was, I was able to purchase up front. I acquired more space than I thought I would need. I brought in people that worked really well as a team. I found a bank that was a blessing to work with. And I was able to move a large proportion of my patients that left Bascom Palmer and came with me. So we started busy from day one. But the key
So it sounds like you...
Go ahead.
I was going to say, it sounds like you got a couple of lucky breaks, if you will, if I can call it that. You were very fortunate in a lot of different ways. And you said a lot there, so I'm going to kind of break it down in a couple different parts. The first one is, as the practice grows, you mentioned the people. The people side becomes just as important as you scale up, and you scale up quickly. How do you approach building a team that supports both clinical excellence and the culture you want to create at your practice, and how do you maintain that culture as the staff continues to grow and expand?
Right. So I think you hit the nail on the head, because you need two things, particularly in a non-academic practice. You need excellence in your people, but they have to be team players. And one of the things that was obvious at Bascom Palmer is that people very strongly felt they were working for the university. We feel like we're working for each other. So that idea of, we're in this as a team together, that is critical to the practice success. And it's particularly critical in a busy vitreoretinal ocular oncology practice. So your team has to fit together. So I will tell you, I not only have some of the smartest people I've ever worked with, but I clearly have the nicest people.
And I was going to ask you, so with that mindset, you mentioned working for in the academic setting. The mindset is they work for the university versus working for, towards a shared goal amongst, you as obviously their leader, but also as a team. How does that translate to overall patient care?
So I think you already know the answer, Spence. So when people are invested, whether it be me in my practice or my tech and my patient, they perform better. Okay. Mm-hmm. So nobody's doing, I really feel strongly that this isn't about a job. I think healthcare is a unique, focus, and it's pretty demanding. We have some really sick patients, and we have elderly patients, and we have infants, and it really crosses the gamut of our society. You have to be able to flex. I'm in Miami. You can imagine, I think I'm probably the only person on my staff who's not as bilingually excellent as I should be. I've gotten a lot better in private practice. There wasn't so much of a push for me in academics. So my staff, what I love is, so yesterday in clinic, we all have busy clinics. Most retina specialists seeing 75 or 80 patients now and doing injections, 40 or 50 injections a day. The volume is high and the pace is fast. But I get comments every single day about how amazing my staff is. I don't want them to tell me that they think I'm amazing. I want them to tell me that Alex and Paula and Carolina were the best techs they've ever seen. My front desk was amazing. My photographer is terrific, and my ultrasonographer is amazing. So that's what drives you. And what I tell people in the office too is many times they're me. So the patient looks at the entire experience, and that's how they measure how their experience went. It's not like, oh, Dr. Murray's amazing, he made the right diagnosis. They're looking at, oh, I could park my car pretty easily and walk into the office, and the front desk person made checking in super simple. I think that in academics, you don't really appreciate that, because you're divorced from the registration and the front desk. And in many academic centers, every patient goes to a photography center or an ultrasonographer.
Right.
They're kind of in that group of patients, but they're not with any one person. So I've loved the tie to my patients. I feel I have a much better integration with my patients than I've ever had in my practice. And I've been doing this a long time. So to still be passionate about it and to still love doing it, you have to do it with people that are amazing.
Yeah, of course, I totally agree. And there's like continuity from the top down, and you as the founder and leader set that tone and really establish that culture so everyone really follows your lead. And again, it's an extension of you through their services, whatever their role is within the practice. And that translates that to that very high level of patient satisfaction and overall patient journey throughout your clinic, I'm sure.
Right. And then the other thing, Spence, which is interesting, is that patients are very time conscious.
Yes.
And in the academic centers, time is not a priority, okay? You can go in, and when I left Bascom Palmer, clinic visits were taking 5 to 6 hours, okay? And in that 5 to 6 hours, hardly any of that time was with the doctor, right? It was all just place to place to place. It's kind of funny because my patients are still with me. So I had somebody go, Dr. Murray, it took us 90 minutes to finish our appointment. And I was like, and she goes, well, usually you see us in less than an hour. And I go, do you remember Bascom Palmer? And she looks at me and goes, we don't talk about that anymore. And I go, yeah, because you took 5 hours at Bascom Palmer, and now you're unhappy when it's an hour and a half. I go, we've really changed that bar. But it's also true, Spence, that people shoot and the bar is not the same. So it gets higher and higher and higher and higher and higher. And that's a little bit of the fun of it.
Well, it's I think a testament to, again, you've raised the standard, so it's almost like a badge of honor, the fact that they're complaining over an hour and a half versus just years ago they were pretty much okay with sitting around for like 5 hours. So speaking of team and workflow, technology plays a massive role in that equation as well. As a specialist in retina and ocular oncology, you rely heavily on advanced imaging and diagnostics, as you mentioned before. How have you balanced investing in cutting-edge technology while keeping operations efficient, lean, and scalable as a practice?
Yeah, so I think that's a great question because, as you know, technology can be shockingly expensive. And we don't think of technology costs in academics. because you're not buying it. The university is buying it from the hospital side for you.
Right.
You have to argue for it maybe, and you have to budget for it with them, but no skin off your teeth, not out of your pocket. Totally the opposite in a non-academic practice. Every piece of equipment that you have, you've purchased. Now, once again, that's where having a good relationship with your bank is important, and you have the opportunity to amortize your deductions, so that there's a lot of business to what you do with purchase other than just what it costs. But having said that, we looked very closely, and what we've done is we stepped up to OCTA incorporated in our system. So now we can do, angiography, OCT angiography, without having to inject our patients.
Okay.
It's different from fluorescein or ICG, and my equipment was set up to do fluorescein and ICG, but a non-invasive study that gives you almost as much information, huge step forward. And then the other thing, as you heard, was the wide field imaging integrated with OCT. My patients have tumors in the periphery, or they may have a retinal tear. We can use the camera systems now to go right to that area. In some offices, what they've done is they've started almost a telemedicine approach where they use the imaging to document their exam, and in some places replace the exam. I am very opposed to that in many ways, because for me, so much of my disease for my patients doesn't fall into even a wide field photograph. And so if all you see is the photograph, you may totally miss the peripheral tumor or the tear in the retina, or the vascular lesion. So we do all of the imaging, and then we look at our patients. And I think the gold standard has always been look at your patients, and that's still the key. But you can look better now, Spence, because you've got imaging that immediately shows you the nerve, the macula, the vasculature, the peripheral. Usually the horizontal periphery is seen really well, and then the lids fall down, a little bit, and you don't really get superior, inferior. But you can see things and document things now that were almost impossible to see and document in the past. And I think that for me, I couldn't practice without the technology I have. I would not feel that I was providing the best care to my patients. And I think that's really what this is about, is how do you continue to deliver world-class care? And you have to scale your equipment.
Mm-hmm.
And sometimes it's a big hit. You have some significant costs associated with that.
Mm-hmm. Well, if we're talking about equipment, got to touch on lasers because it's me.
Right.
As you know, lasers are essential to many retina treatments. From a business perspective, how do you weigh the cost, utility, and ROI of investing in laser equipment, especially in a private practice setting like yours, especially with the rise of anti-VEGFs and other pharmacological medications that address what lasers used to in the past?
Well, the saving grace for lasers, Spence, is that their reimbursement is amazingly good, right? So if you look at procedural reimbursement, you get reimbursed for lasers better than any other technology that we employ. Having said that, the use of lasers has really declined. But there are things that are amenable to laser only. You can't do an anti-VEGF for a retinal tear or a localized detachment. Anti-VEGF has that vascular response, and it has lowered the use of laser for macular edema, and it has lowered the use of laser for proliferative retinopathies, but it hasn't excluded that. And in fact, many people are looking and saying, we start with an anti-VEGF, and then we assess whether we need to consolidate that with a peripheral laser treatment. I think that's a totally reasonable approach. So you can't just not have a laser. You have to have a laser, and what you want in that situation is a multifunctional laser. So I want to be able to put a headlamp, indirect on if I have to laser the periphery, and if I want to do subthreshold laser, I want to think about that as an option. So I was very thoughtful about what laser would benefit the practice the most.
So, of course, all this is ultimately serves one major purpose, delivering a strong patient experience, as you mentioned. So, in a high acuity specialty like retina and ocular oncology, what strategies have you used to create a consistently positive and reassuring patient experience, and how do you measure that satisfaction? And I think you touched on it before. If you want to add anything else, and I will mention, if you don't know already, you probably do, that you actually have a 5-star rating on Google.
Yeah. So I try not to look at ratings, but that does come up all the time. And I think patients are very influenced by ratings.
Yep.
So it's kind of like if you're looking at a restaurant, you're looking to see, what's the Google rating, what does OpenTable say, what's Yelp review. We've gotten so accustomed to that for everything that people do that with doctors. So I think you're right. We have to be attentive to that. What I think has been good for us is that I have a very genuine staff and our focus is patient care. And you're absolutely right, Spence. When you look at it, people that come here with either a life-threatening illness, a tumor, a malignancy, or they've got a vision-threatening disease where they can be blind. And every study across the U.S. has said, what are the two things that our population fears? They fear cancer and blindness. And what do I do? Cancer and blindness. So, it puts you right in the heart of things from the beginning. But what I love is that we've come so far with our treatments that I almost always can have some path for the patient to do well. And part of that path is bringing the patients into their own care. So I will say, and I say this often, your part of all of this is you're going to use your drops, you're going to take your pills, and you're going to keep your appointment visits. That's your part of this. And when you're out of this office, you're going to be healthy. Your blood pressure is going to be good. Blood sugar is going to be good. That's our compact together. We're in this together, and your part is just as important as mine. And the biggest thing that I see, particularly with the anti-VEGFs, is you have to have good compliance on follow-up. And we have patients, we saw someone yesterday, they have a 28-day appointment. If they come in at 31 days, they're worse. So they can tell me at day 28 to day 29 that there's a worsening. So that's a good patient because they're going to push to come in at 28 days. But I really push my patients to say, look, you've got to come back. You've got to take good care of yourself. You're a big part of this. And I think that patients are respectful. If you're in it with them, if they feel confident in the care you're going to deliver, if they respect the evaluation, the examination in the office, they organically give you a good review, okay? Mm-hmm. And I think you've got to talk to your patients as they are. And I have crazy practice because we have parents with kids and we've got grandparents with their children. And so it really spans the spectrum. And we're seeing older and older patients because everybody seems to be living longer and longer. And as they live longer, a lot of these diseases become cumulative. So you need good eye care. And I look at them and say, my job is to keep you seen, okay? You may die from a heart attack or a stroke, but you're going to do it with good vision. And that's my part of that deal.
Well, that's your promise. I'm sure you deliver on a pretty regular basis. So, but as your practice has grown, it's almost somewhat related. How have you approached, say, like branding, referral relationships, and community outreach, especially in a competitive market like Miami? And again, with all the social, I see a lot of practices have like a social media manager and kind of dive into that area. I mean, what's your take on that?
So if I was 20 years younger, I'd be all over that. But I grew up where this wasn't important. So I'm doing this with you and never would have thought that would be something that I do. But I think it's important to really use these educational opportunities to reach out differently. So I speak in the community, I speak regionally and nationally. I do things with patient support groups where I'll talk to the support group. I think that's part of giving back, and I'm not doing it because I want a good Google rating. I'm doing it because that's what I would want my doctor to do if they were taking care of my mom, for example. Mm-hmm. So, but having said that, I think that you've got to really be dependable. Don't take on a task if you're not going to do it really well. That's my big thing, because people are looking at what you do all the time. And if you're doing what you do well, better to do less than more. So that's good. But yes, traditionally, so I'm all over a little bit more than I would have thought I was. I'm the editor-in-chief for the Journal of ASRS, which is Journal of Vitreoretinal Diseases, and we started this author podcast thing. So I was like, nobody's going to listen to these, and just the opposite occurred. And what's funny, Spence, is that my patients come in and they're like, I saw you on YouTube, and I'm like, what? And they're like, yeah. So I'm like, you watched a YouTube about academic manuscript, and they were like, yeah, it was amazing. I think people, one, they want to see you if they know you. That's a huge part of this. But two, we're so visually stimulated with things like Instagram and YouTube, and people want to look at stuff, and good content is good content. So yeah, I'm always surprised how many people have seen me on YouTube.
Well, I'll tell you this, while growth is exciting, it also comes with some complexity. As practices expand, it's easy for quality to slip through the cracks. What safeguards or systems have you implemented to ensure clinical excellence and consistency across your operation?
So I think that's really important, because we're a big practice with a small core group of people. I think my staff works as hard as any staff in the US. But what I love is that we all agree that we want to work really hard and be done. They're in control of that flow. So I think empowering your staff to be part of the process is important. Everybody looks at everything. So if we put you in an electronic queue and somebody finishes earlier, they'll pull that patient in and help someone else out from the tech standpoint. Ultrasound, if we get behind, we split the ultrasound off and do that. So I think you want everybody to realize that it's not just my little part of this, we're all fit together like a puzzle, and we don't finish till we all finish. I think that's really important. I think that they know that my staff knows how big a role they play. And they know that I appreciate the fact that we have a large volume of patients, but they know that's not what is my focus. So my focus is taking great care of every patient one by one.
What I love about what you just shared there was, number one, first of all, you're a really good communicator, and that translates really well to any team that you lead, being able to communicate your vision, your message, and then respond to it if you're a good communicator, and you obviously are. But the one thing you just said was the empowerment piece. As a leader of teams throughout my career, that's the one thing I've always prescribed, to empower them to make decisions and even make mistakes in some cases, because we'll all learn from it. And again, they get more, if you want to call it buy-in, they're more bought in, and they become a part of that same vision, and they are all in at 100%. Again, sharing that vision with you, and really, as they say, rowing the boat in the same direction. And those are the kind of people you want on your team, and you want to create that culture, which you obviously have with the smaller team you have. Oftentimes when clinics grow, they add more people. What you've done, seems like you've got still a really small, tight circle who just do things really, really well, and also they are cross-trained, it sounds like. So when things really get, high volume, high patient flow, people start to split off and do other things or multiple things to keep patients moving through, but still achieving a very high level of and standard of care.
And Spence, there's more than one way to do this, right? There's not just the golden answer that's the same for everybody. And I think that you have to look at your circumstances and your team and your patients and find what's best. What's fun for me is that my operations professor for my MBA is one of my patients. And so he always comes in and he goes, is this a 3-channel model? And I'm like, no, it's just taking care of my patients. He loves the office because his experience is really academically focused. And then he comes here and he goes, wow, this is like a real life experience with high volume, multi-space. It's a beautiful example of how you can take different approaches to patient care. One of the other things some offices do is they have their tech be their photographer OCT person. So they'll throw in an Optos unit in each room, and the tech will tech you and then take your pictures in OCT. Mm-hmm. So that's reasonable. I was lucky when I bought the office, we looked at the office flow. So there's a flow in my office that is geographic, taking you right along the path. So it allowed us not to have to pull everybody to do everything, but to allow people to specialize on what they're really good at. But the most important thing is I have amazing people who work really hard. And remember too, we see these patients over and over again. So this isn't a one and done experience. You get to look at your patient, and I mean, I have patients that have seen me since I started at Bascom Palmer in 1991. I've taken care of their grandchildren. I mean, it's like generational. So,
Oh, wow, okay.
but I love that. So my daughter's thinking of going into medicine. I'm hoping she may do ophthalmology. And what she realizes is when she comes to the office, it's such a diverse experience in culture and language and focus. She's like, this is great. You take care of everybody. And I think, when we talk about ophthalmology, medical specialty, surgical specialty, I love to operate, high imaging, which is my favorite thing, and hands-on with your patients. So very few specialties allow you to have that level of interaction. I think retina and oncology in particular, it's a blessing to me to be able to take care of my patients because they're entrusting you with everything that's important to them.
Mm-hmm. Well, thanks for sharing that. So, first time I've ever brought this up on this show, but given again your background, how long you've been in the industry, and you have that time, in role as what you do as a surgeon in ophthalmology, to I think comment on this. So, private equity. You mentioned it earlier. The topic of private equity is increasingly prominent and polarizing in ophthalmology, as you probably know. As someone who's scaled independently, how do you view the growing trend of private equity acquisition, and what should physicians consider carefully before taking that?
So, I think the key is that for some of the private equity space, there are some really good people there, and they have brought in some really good practices. And those practices have been able to leverage quality and patient care as part of their process. The issue with private equity a lot of times is you feel less vested in the practice. And a lot of times people are saying, this is my exit strategy. I want to do something with my practice, and this is what to do. I always worry about the young people because the equity acquisition really targets your senior people, not your junior people. And then if you go into an equity practice, how do you develop ownership in the practice over time? Traditionally, one of the reasons you went into private practice was so that you could move into a practice that would be yours. Even if you started in someone else's practice, you grew into partner, and maybe you did the senior partner, and maybe you'd end up with the practice as yourself. We understood that. So the pathway with private equity is usually a much higher level entry salary for private equity acquisitions, but maybe not as much potential to grow that compensation, and maybe less say in how things work. And equity is not just hitting ophthalmology, as you know. Private equities, we're seeing it across the board.
Yeah.
And it's kind of interesting because some of the early data is suggesting that costs go up with private equity, patient costs. And I was kind of thinking costs would go down because of scale. And so it's going to be, I still think we're in this disequilibrium. I think we've got a ways to go. But I've got to say that my friends that have gone into private equity and been involved with acquisition, they're some of the best people in the country, and boy, they are not unhappy. So, and then for example too, when I started, nobody wanted to work at the VA. The VA
Right.
was kind of you're shunted aside to the VA. Optometry let them take care of the vets. My dad died in service, so the VA's always had a close touch with me. And what I've seen is there's a huge improvement in quality of care in the VA system. And really good people want to go there, and salaries are competitive now, and time is good. So I think overall the quality of retina care in all of these different spaces has really improved. So I find that exciting. But at the same time, you're looking in a crystal ball and saying, where's it going to go? What's AI going to do? How is that going to impact us? So, but it's fun. It's fun to see the changes.
Yeah. So, I mean, I've met you. We know each other fairly well. You're a positive guy. You're enthusiastic. You're passionate about what you do. That's all well and good. But let's just take a moment to take a look at the personal side of things and leading this growth. Owning and scaling a specialized ophthalmic practice is a demanding role, as I'm sure you've learned over the past 13 years. How do you manage stress, decision fatigue, or burnout? What advice would you give your younger physicians taking on and thinking about starting their own practices?
I think you hit the nail on the head, okay, which is I find private practice at this level was incredibly more stressful than my academic practice. I had one of the toughest academic practices in the country, but at the bottom line, I wasn't tied to the practice financially. It wasn't my building, it wasn't my space. I did feel my staff were my people, so I did have that already. But I think when you go into a practice like this, you realize that you are the reason that 15 people have a full-time job, and you pay the mortgage and the operating cost and the drug cost. And if you're in a solo private practice, you pay it all. So I have had a few sleepless nights at the beginning, wondering how things would work out. And I think we all suffer a little bit from that imposter syndrome at times, where you're kind of like, am I that person? Can I do this? But so Spence, I think that stress is inherent. I mean, if you're a caring surgeon and you do complex things and you're not stressed, you're not paying attention, okay?
You may be doing it wrong.
I mean, that drives me. And I will still, to this day, if I'm doing something really unique, I sometimes have a hard time sleeping the night before the OR. I think about it.
Even now?
Even now. And I'm not young, okay? So, but I respect people that are like that, because I think that you are driving yourself for excellence. You are like, and you have to. I mean, a lot of these patients, really, you're their last hope to stay alive. You're their last hope to see. So, and bad things happen. One of my patients that I love, that saw me this week, we do almost all our cases now under local anesthesia. So the patient is awake. When I trained, every patient had general anesthesia, right? Now my patients are wide awake. So I was operating with a fellow, and the fellow said, and every time this patient comes in the room 20 years later, that's what he says to me. He looks at me and goes, and I'm like, really, Jimmy, still? I mean, it's 20 years, man. You're 2020. You can let it go. I mean, you realize you touch these patients' lives in amazing ways, and the gratitude is huge, but there is some stress to that too. The biggest stress for me has not ever been sort of the hands-on patient care, to be honest with you. It's been the finances of a major office like this. When I refinanced the practice, I wanted to do a swap, and I really didn't have a lot of experience with that. And the bank is like, do you really want to do that? And I go, yeah, I think I really do. And so, in hindsight, it was a great choice, because interest rates, were skyrocketing after that. And so it was locked in with that, and it pays off the thing. But I was stressed. I mean, I was stressed. And I have to juggle money sometimes to say, I got an unexpected $50,000 bill. Who's expecting $50,000, unexpectedly? So, and then the kids go to college, and then she goes to medical school, which is great. I'm all about education. But I think if I would say anything to my younger self, I would reiterate how important financial planning is, and start early, and save well, and be thoughtful.
Right. So eyes on the future, Dr. Murray. Looking ahead, what's your vision for the future of your practice, and what trends do you see shaping the next phase of private ophthalmic practices, particularly in the retina and oncology, ocular oncology space?
Right. So I think solo practices like mine are going to go away. Yes, I do, because the upfront cost is too high. The stress level is high. The reward is high, but you can do other things and lower your stress, maintain your reward, and start off with less compensation concern. So I think people are going into private equity, or they're joining existing large group practices. I don't think there's this big flux of let's start my own practice with one person. And if you look across specialty areas in medicine in general, that private ownership group is getting smaller and smaller and smaller. You're seeing two types of acquisitions. Hospitals are buying practices if you're not in equity, and then equities acquiring practices. So I think the space is going to be multi-group, equity, academic, and VA. I think that solo practice is likely to go away. Now, when I bought this practice, I'm like you, I was always thinking scalability. So this practice is equipped to see 3 full-time physicians in this office, and it's just me. So I'm thoughtfully thinking about how do I move forward? What's the future? I want to make sure that this practice will live on in the way it is for the patient care in this community long after I'm gone. And believe it or not, I spend a lot of time thinking about how to do that best. And it's not an easy thought. But I think for the people that do go into private practice by themselves, if you have that right mindset, there's nothing more rewarding, amazingly rewarding opportunity. And from the stress perspective, to get back to that, surround yourself with great family and great friends. So when you work with people you want to be with. You are in your office all the time. And then when you go home, try to make the most of your time with your family. So you might know a little bit, I'm a boating guy. So when I came to Miami in 1991, I had never really been on a boat before. I bought a 42-foot sailboat and I lived on it.
What?
In the Miami Beach Marina.
Nice.
So I lived on a boat for 5 years, and that's how I learned how to sail. And
very cool.
I bought a townhome that had a place for my boat, and then my wife told me that she didn't want to sail; she wants to go somewhere. So we sold the sailboat, which broke my heart. And then I lasted about a year, bought a powerboat. And now we have a really nice house on the water, and I have my last powerboat. I can't imagine getting another one. And that, I would say that if you were to ask my friends and family, they would tell you that's my happy place. Other than ophthalmology and retina oncology and the academic stuff that we do for the societies, I love to be on the water or in the water.
From a surgeon who has truly been there, done that, and achieved marked success, you bring a level of sage advice that is hard for anyone to ignore, Dr. Murray. On behalf of those in the Q-Switch audience aspiring to follow your lead, I want to thank you sincerely for sharing your thoughts and experience on today's subject. Before we sign off, if anyone of our Q-Switch audience want to take a deeper dive with this subject with you or learn more about your practice, what's the best way they can contact you?
So best way is email me, tmurray, T-M-U-R-R, at Murray, M-U-R-R-A-Y-M-D.com. And I'm pretty good about getting back, and we'll go back and forth with that.
Yeah, you are indeed. I've been able to track you down because you are so responsive, which is a rare quality to find in some doctors, believe it or not. So as always, we'd like to thank Riverside FM and Passionate Media for making this show possible. That's a wrap for this episode of the Q-Switch Conversations podcast. Until next time, this is Spence, and I am out.
You're listening to The Q-Switch with your host, Spence.